welcome to this edition of DermTube Journal Club. I'm Dr. Nancy Samolitis, your host, and I'm here today with Dr. Ron Prusik from Washington, D.C., and we're going to be discussing comorbidities associated with psoriasis. Welcome.
Thanks, it's great to be here.
So tell me first, what are some of the most common comorbidities with psoriasis patients?
Sure. Well, comorbidities are related to the systemic inflammation. So the most common one is psoriatic arthritis, but there's others like inflammatory bowel disease, fatty liver disease, depression. There are many different comorbidities that we need to think about when we see our psoriasis patient, because comorbidities really are a major cause of mortality and morbidity in our patients, and they're actually a big cause of the cost to the healthcare system for our patients and insurers. About a third of all the costs related to psoriasis are due to the comorbidities.
What are some of the cardiovascular risks in psoriasis patients?
Well, we know from looking at the UK General Practice database that patients with psoriasis, especially severe psoriasis, live 6 years less than the general population, and that's related specifically to their cardiovascular risks. So we did a study that was published in JAMA Cardiology in September that was led by Dr. Nehal Mehta and Dr. Joel Gelfand that showed that if we can reduce PASI scores by 33%, we can significantly reduce aortic inflammation, equivalent to what you get with Lipitor.
And what about depression and psoriasis? Which patients are at high risk here?
Well, psoriasis patients are at risk depending upon the severity of the disease. So the more severe you are in your psoriasis, the more the risk of depression. But even mild patients can get depression as well. We know from a study that was done in Sweden that they did surveys on adult patients with psoriasis, and those adult patients were found to have higher risk of depression, anxiety, and personality disorders if they developed their psoriasis at a young age, 20 or younger. So we want to treat those patients a little more aggressively because they have the highest risk for developing problems.
Do we think, therefore, that patients with depression have increased inflammation in their body?
We know that patients with depression but don't have any autoimmune diseases such as psoriasis do have elevated cytokines such as elevated TNF-alpha, elevated interleukin-17, IL-1, TGF-beta. So patients with depression in itself have elevated cytokine levels.
And what about fatty liver disease in psoriasis patients? What can they do to reduce their risk?
Well, patients with psoriasis have a high risk of fatty liver disease. In the US population, it's about 30% of the population, but in our psoriasis population, it's about 60%. And our psoriasis patients are more prone to developing the severe type of fatty liver disease called NASH, non-alcoholic steatohepatitis. So they can prevent that progression with exercise, with weight loss. So if you lose 10% of your body weight, you can reduce fat. Exercise can reduce inflammation. Drinking 2 cups of coffee a day actually helps reduce inflammation in the liver as well. Correcting your vitamin D deficiency helps, and also avoiding alcohol and avoiding medications that increase your lipids or methotrexate that might affect your liver as well are all important things that you can do.
Speaking of vitamin D deficiency, are psoriasis patients more prone to bone fractures, and what's the role in vitamin D?
Yes, we know from studies that our patients with psoriasis are more prone to vitamin D deficiency, especially those with larger BMIs. And the vitamin D deficiency can cause an effect on your T suppressor cells, which could make more inflammation. And also vitamin D deficiency can affect your bone demineralization problem. We know from studies that patients with psoriasis have more pathologic bone fractures. And this is thought to be caused from elevated cytokines. So we know that elevated TNF-alpha and elevated interleukin-6 cause bone resorption. And we also know that if you use topical steroids for long periods of time, there's a theoretical risk of having bone demineralization. So those are all why patients with psoriasis are more at risk for bone fractures.
And what is the role of the dermatologist in recognizing these comorbidities in our psoriasis patients?
Well, I think that the role is that we have to think of our patients with moderate severe psoriasis as having systemic inflammation. So when I see my patients, when I'm trying to treat them, I'm thinking, What am I going to use? Well, I'm going to think about the drug safety, the efficacy, but also the comorbidities the patients have. So do they have abdominal obesity? Do they look at their medication list? Are they on medicines for depression? Are they on medicines for elevated blood pressure or cholesterol or blood sugars? They may have metabolic syndrome, so they'd be at a higher risk for fatty liver disease and heart disease. So we'd want to treat that systemic inflammation based upon their comorbidities as well.
And finally, is there any thought that psoriasis treatments reduce the risk of the comorbidities?
Well, we have some preliminary studies that actually, when we treat patients with psoriasis, we can reduce the heart attacks and strokes based on studies with TNF-alpha blockers, and we have some data with interleukin-12 and 23 blockers, and we're studying that with all the other biologics as well. We also know from the SOLAR registry that patients who are on biologics versus the ones that are not actually have less MACE events, less heart attacks, less strokes. And also we know from the SOLAR registry that was just published in January of this year in 2018 that they have less depressive symptoms if they're on the biologics as opposed to not being on the biologics. We also have some data with large population groups that the standard mortality ratio can improve on patients who go on biologics with psoriasis because we're reducing the systemic inflammation, the heart attacks and stroke risk. We want to really understand, the comorbidities. If we can treat the patient with psoriasis at an earlier stage, can we actually prevent a lot of these comorbidities? So we need good outcome studies, and I think this will be very helpful in the future.
Well, thank you so much for joining us today.
My pleasure.
And thank you for joining us on this episode of DermTube Journal Club, and we'll see you next time.